We welcome you all to the 31st webinar of IAPWC Goa. I, Dr. Smarnika Das from the technical team, welcome you all. So we have been running a series of webinars on PCOD, and this is our sixth webinar in the series where we wanted to take up a most common topic that a PCOD client patient wants to know is about conceiving. So, infertility is seen a lot in such cases, and that is why we thought that we would get a specialist on board who would give us an idea about what exactly it is and how can we treat this particular condition. So we have with us Dr. Sachin, who would be taking up the topic. We have Dr. Lavi, who would be hosting today's webinar. So without much ado, I would like to ask Dr. Lavi, please take over. Also, Dr. Melissa would be taking the question and answer. So Dr. Lavi, can you please start?
Am I audible?
Yes.
Okay. Very good morning to one and all. Thank you, Dr. Smarnika ma'am, for giving me this opportunity to host for today's webinar. I, Dr. Lavi Jain, would like to welcome you all on behalf of IAP Women's Cell Goa for the series of webinar. Today's topic is infertility. What, when, and how we treat it. It gives me It gives me immense pleasure to introduce our speaker for today's webinar, Dr. Sachin Narvekar, sir. Dr. Sachin Narvekar completed post-graduation in obstetrics and gynecology from Goa Medical College. Subsequently, he has worked as a lecturer at Christian Medical College, Vellore. He has developed keen interest in the field of reproductive medicine. He has underwent subspecialty training in assisted reproductive technologies and assisted conception center at Bangalore. After returning to Goa, he along with his colleagues started the IVF department at Vision Hospital, Mapsa. He has published scientific researches, articles in peer-reviewed journals and has presented papers in scientific conferences. I welcome you, sir. I now request Dr. Sachin, sir, to take over.
Very good morning to all the participants. And am I audible? Hello?
Yes, sir. You're audible.
Yes.
Thank you, Dr. Lavi. And I am really honored to be in talking on this forum. Thank you, IAP, for inviting me. And so today I will be talking about infertility, what, when, and how we treat it. Is there some, I cannot change the slide. Hello?
So your screen share is on. You would just
Yes.
enter. Yeah.
Yeah. So having a child is one of the most beautiful experience in for a couple, but unfortunately, it may not happen in a few couples. About 1 in 6 couples will have difficulty in conceiving. In the last few decades, infertility is showing a rising trend all over the world, and also in India. It is estimated that about 60 to 80 million couples worldwide are childless, and in India alone, out of this 60 to 80 million, 15 to 20 million are childless. So there is a growing demand for the number of treatment cycles have increased, number of IVF clinics have increased. So why is this happening? This could be simply because of some changes which has happened in our society. The lifestyles have changed. Childbearing age has increased. Initially, many years ago, women used to have baby and complete their family by 24, 26 years. But now the average in Goa, I feel, is about more than 30. Also, stress at work, environmental factors like pollution and obesity, lack of exercise. All these may be the contributing factors. Fortunately, the science has progressed and we have been able to obtain a deeper understanding of conception. Assisted reproductive technology has also progressed, and many couples have benefited from it. So today I will be talking about, in the next 1 hour, the science behind conception, what are the causes of infertility, when should a couple approach a doctor, what test do we do, how to optimize natural conception, which patients need medical treatment, and how we treat them medically. We are all aware about this anatomy of the uterus, the two fallopian tubes on either side, the ovaries. Every month, one egg gets released and it gets sucked up into the fallopian tube and it gets transported by a conveyor belt, which is actually the cilia. These hair-like structures are called as cilia. So these cilia are delicate hair-like structures and they transport the egg, and the egg comes somewhere in the middle of the tube and waits for the sperm. When the sperms get deposited in the vagina, millions of sperms get deposited, but about only a few thousand reach the fallopian tube. Out of this, a few hundred come near the egg. And out of this, only one sperm is able to fertilize the egg. So the egg is very selective. It gets fertilized only by one of the best sperms in that cohort. After fertilization, which happens in the fallopian tube, we get something called as a zygote, which then divides to form a 2-cell, 4-cell, 8-cell stage embryo. So the main early development of the embryo happens in the fallopian tube itself. And by the 5th day, we get something called as a blastocyst. And it comes in the uterus. And by the 6th or 7th day, it implants into the endometrial lining. So you see, the process of conception is a multi-step process. If one of the steps doesn't happen in one cycle, then conception will not take place. So in human beings, it is an inefficient process, meaning in 1 month, a woman has got only about 8 to 10% chance to conceive. And this becomes about 50 to 60% after 6 months. And after 1 year, 80% would have conceived. So what is a fertile window? I am often asked about this fertile window and a number of questions like how frequently to have relations, what is the position, what is the impact of spillage. Well, the fertile window is a 6-day window period. You can see on this graph, which ends on the day of ovulation. The 0 is the day of ovulation, and it starts about 6 days before ovulation. We have to understand that the sperms survive for 3 days in the uterus, whereas the egg survives only for about 12 to 24 hours. So if the couple has a relationship every 2 or 3 days, that is sufficient because the sperm survive for 3 days. So actually you can see the peak fertility is actually 2 days before ovulation. But we don't talk about this fertile window to the patients. We just tell them to have relationship every 2 or 3 times a week. That's enough. Because if we tell them that this is the day you should have, then the man gets all worried and stressed out because there is no spontaneity. So in our department, we don't talk to them about the fertile window. We just tell them have relations every 2 or 3 times a week. That is enough. Well, the position and spillage have no impact at all. So what exactly is infertility? We say infertility when a couple, after having regular sexual intercourse at least for a year, they are not able to conceive a child. As I said, 80% will have a baby by 1 year. Out of this, 20%, those which remain without a child, 15% will have in the next year. Only 5% will have a problem. So beyond 2 years, if they don't have a child, only those people might be having a problem. But we don't wait for 2 years. We start investigating after 1 year, but not before 1 year. But in women who are older, that is above 35 years, because they don't have time, the age is catching up, we take the cutoff as 6 months. Basically, this 1 year and 6 months, these are arbitrary cutoffs. One may investigate even before that, but usually in the clinic, we follow this protocol. So what are the causes for infertility? Well, it is not only the female, the woman who is responsible, but you can see here 30% the men and the women have equal share in this problem. 30% may be combined, whereas in 10% we may not find a cause. That is called as unexplained infertility. We have not been able to find a cause where everything is normal, all the tests are normal, but still they don't conceive. We call that as unexplained. So coming to the problems which may delay fertility in women. One important problem that we face nowadays is too much of fat, obesity. Too thin patients also may have a problem. Now we are aware of this definition of BMI. In South Asians, we take the normal BMI as 20 to 22.9. 23 to 24.9, they are overweight. Above 25 is obese. Whereas this is different for the Western, where above 25 is taken as overweight. But for our population, South Asians, this is the criteria. So many women, I talk to women, the first thing that when a couple comes to us, we talk about obesity, about weight reduction. Many a times, it is very difficult to convince the couple about weight loss, because they say, oh, my neighbor is so fat and she's having 2 kids. So what is the issue in that? But then we have to tell them that some people are super fertile, meaning we do sometimes a fallopian tube cutting, that means a tubectomy surgeries. In some people, when they're family planning, when they want to do a family planning surgery, we cut the tubes. In some people, these tubes join back and the women conceives again. So these people are actually super fertile. So all women, all couples are not the same. And when there is a delay in conception, it means that the body is telling that there is some amount of subfertility. So it is all about optimization of fertility. And the fat is not an inert tissue. Now research has shown that the fat secretes a lot of hormones like leptin, adiponectin, resistin, etc., which can cause hormonal imbalance, impaired egg formation, increased risk of miscarriage, increased risk for gestational diabetes, that is diabetes during pregnancy, and hypertension during pregnancy. So the other factors are alcohol and smoking. Fortunately, this is not a problem in women. Consumption of caffeine, excessive consumption, that is 2 or more than 2 to 3 cups per day. The other important causes are problems in egg formation or a problem in the quality of the egg. The egg might be forming, but the quality of the egg is reduced. Or if the fallopian tube, we have seen the fallopian tube is very important. Sometimes the fallopian tubes might be blocked, or there might be some fibroids in the uterus. Or lastly, endometriosis. I will be talking about it. So problem with egg formation. Now in women, sometimes the egg may not form every month. And this may happen in 30 to 35% of women with infertility, that the egg may not form. And one important condition is polycystic ovarian syndrome. There are some other hormonal imbalances, out of which the important is thyroid, which also causes the egg not to form. The other important problem is a poor quality egg, and that is because of age. Advancement in the age leads to decrease in the quality of the egg. Well, the polycystic ovarian syndrome is one of the most common endocrine problem which we face in our routine practice. About 2 to 20% of women who come with infertility have this problem, or maybe in some cities it is about 30 to 35%. Well, what is this polycystic ovarian syndrome? Polycystic ovarian syndrome is basically is because of a metabolic gene. There are three criteria for this. How to diagnose polycystic ovarian syndrome? One is excessive male hormone. Second, irregular cycles. And third, polycystic ovaries on an ultrasound. So now this metabolic gene is quite common in South Asian population, but not all manifest all these symptoms. And we have found out that there are some environmental factors which actually switch on this gene. And the reverse is true. If we take care of these environmental factors like obesity, unhealthy lifestyle, the gene gets switched off. So what are the manifestations of this gene? One is a hormonal imbalance. There are a lot of eggs seen on the ultrasound. Here we can see the ultrasound picture in polycystic ovaries. A lot of eggs are there, but they don't ovulate, they don't get released, they get blocked at a certain stage. As a result of this, when there is no egg, there is infertility. So one important thing that a patient is advised is, if she is obese, then she must lose weight before doing any other treatment. That is the first thing. Now, there is a condition called as a lean PCOS, wherein a woman may be thin, but still have the same problems. Well, we don't know much about this because we are still researching, and these are a little difficult to treat, actually, a lean PCOS. So how does the age affect the chances of conception? You can see in this graph, fertility, the best time to conceive is around 24 to 29 years. But because as the age advances, the fertility goes on decreasing, and it has a sharp decline by the age of 37 years. Also, we can also see that the chances of having a miscarriage increases with advancing age. This is the plot for spontaneous abortions. So why does this happen? Mainly, there are some chromosomal errors which happen during division, during the formation of the egg, as the age advances. So this is very important. The 25 to 29 years is one very important age group where I feel women should plan their baby. So now coming to the fallopian tubes. Well, in some women, sexually transmitted diseases like chlamydia, gonorrhea may cause a blockage in the fallopian tube. These sexually transmitted diseases, like especially chlamydia, is often silent. The woman doesn't have any problem. Sometimes women may have a vaginal discharge, pain in the lower abdomen, or painful periods, or pain during sexual intercourse, which may make us think that there might be an element of a pelvic inflammatory disease, which we call that. So how do we diagnose it? By ultrasound, we may not diagnose it at all. On clinical examination, we may find a little tenderness on examination. But when we do a tube testing, we may find a blockage in the fallopian tube. We can see here the different types of pictures that we get. Here the tube is blocked at the right at the beginning, and then here the tube is blocked at the end of the fallopian tube. That is a distal obstruction. This is called as a proximal, and this is called as a distal. Another way we diagnose is with laparoscopy. We'll be talking about that. So what about fibroids? Women are always worried about fibroids. Well, fibroid is actually a growth of smooth muscle tissue of the uterus, and 20% of women, normal women, will have fibroids. So fibroid is quite common in women, but does it cause infertility? Usually no. Only it depends where the fibroid is located. If the fibroid is located inside the endometrial cavity or very close to the endometrial cavity, and it is indenting into the endometrial cavity, in such cases we may have to remove the fibroid. And also it depends on the size. If there is a too large fibroid, then we may have to remove it, because it can decrease the chance of conception, increase the chance of preterm labor. So more than 5 centimeters fibroid, we may have to think of removing it. Or if the fibroid is within the cavity or very close to the cavity, we may have to think of removing it. So again, fibroids may have no symptoms at all, or they may have heavy periods, painful menses. And ultrasound is one of the best way by which we diagnose of a fibroid. Treatment here is called as myomectomy, and that is the removal of fibroid. And the best way, that is which we minimally invasive techniques, which we call that, is the gold standard. We use either laparoscopy for fibroids on the uterus or within on the wall of the uterus, whereas hysteroscopy is used for removing of the fibroids within the cavity. So another problem that women face is endometriosis. Endometriosis is a condition wherein the lining of the uterus starts developing outside the uterus. This may be found on the outer surface of the uterus or on the fallopian tubes or on the ovaries. So this is an inflammatory condition. When the lining comes on outside the uterus, it causes inflammation. And women have painful menses, or they may have a chronic pelvic pain, the pain which lasts throughout the month. So many women have painful intercourse or painful defecation. About 20% of women will have some form of infertility. So why does endometriosis cause infertility? Now, endometriosis is an inflammatory condition, and what it does is it hampers egg formation, it hampers the egg getting transported, and it also hampers in all the steps of conception, that is the division and implantation. So because of the inflammation, there is a scarring. If you can see this laparoscopic picture, this is the uterus, and this is what we have done. This is the endometriotic deposits. We have released the adhesions, and see the amount of scarring and the distortion of the pelvic anatomy. So endometriosis is a bad disease to have, actually. And how is it diagnosed? Well, history, clinical examination will show tenderness. Again, on ultrasound, sometimes we may see a cyst in the ovary, that is called as a chocolate cyst. And again, laparoscopy treatment is the gold standard. Now, men are responsible for 30% of the problem. And one important thing is overall man's health is very important for the sperm health, because the sperms are the motile cells. Unlike other cells which are not motile, the sperms are the motile cells. So any problem in the man's health will cause decrease in the sperm count, decrease motility. Now, age is not very important in men, but above 45, the count decreases. But a 50-year-old man can also father a child. But overall, we see that as the age advances above 45, 50, the sperm count and the motility decreases. But it is not as severe as a woman. A woman's age is very important. Now, obesity in man is also a very important problem. And I have seen in my practice that obesity also leads to decrease in the sperm count and the motility. Smoking and alcohol, environmental toxins like farmers who spray pesticides, it also impacts them. It impacts us who eat the vegetables and the farm products, but it impacts them also. Now, exposure to heat. We know that the testes are in the scrotum, which is 1 degree less. The temperature is 1 degree less than the body temperature. So nature has made it like that so that the testes do not get heated up. But policemen, traffic police, welders, people who work in near furnaces, they are exposed to heat, and that can lead to decrease in the sperm count. Also, uncontrolled diabetes. This is very important. We see that men usually neglect their diabetes. So uncontrolled diabetes can also cause a problem. Or sometimes a man may have mumps in the childhood, which can cause problem in the testis. This is a viral infection and it can cause orchitis and decrease in sperm count. Another important condition that we see in men is a varicocele. Now, varicocele may be also found in normal men with who have children, and but it depends on the grade of varicocele. If the varicocele is large, then there might be a problem in the sperm count and motility, because the varicocele is basically a dilatation of the veins around the testis. This is a varicocele actually. This is a normal, these are the normal veins and these are the dilated veins. Now, because the blood flow is increased in these dilated veins, the testis is heated up. So this can cause a decrease in the count. And the treatment for this is, here we ligate the vein here and then the varicocele collapses. But not all men with varicocele need treatment, as it depends on the grade of varicocele. A very severe grade may need. So when should a woman consult their doctors? Most experts believe that 1 year of waiting is important. But if the woman is 35 years or older, 6 months of trying, and then they can meet a doctor. But early consultation is needed if the woman has irregular cycles or painful cycles, or if they have been diagnosed with endometriosis or pelvic inflammatory disease, then they have to visit, or if they have had a miscarriage. So how do we actually approach these women, men and women who come to us? It is ideal that both husband and wife visit us at the same time. We assess the general health of the couple, and if the couple is obese or they have living an unhealthy lifestyle modification is the most important advice that we give before doing any further treatment. Also, coital frequency. It's very important that we advise them that at least 2 to 3 times a week they should have relationship, because if they don't give nature sufficient time, then conception will not happen. So the problem might be just that the frequency of the intercourse is less. So they don't need any treatment. Just we advise them to increase the frequency. Or there might be some amount of coital dysfunction where the man may have erectile dysfunction, women may have something called as vaginismus where the penetration is not happening. That we have to tackle that. Now, vaccination is very important. Nowadays, COVID, we advise all couples before they conceive to have vaccination for COVID. Also, I also check the rubella status. The rubella is a viral infection, and we can understand if the woman has had rubella in the childhood. This is a one-time infection. If the a person has this infection in the earlier life, then they will not have it again. So we check the IgG levels, that is the antibody levels, and if the antibody levels are low, that means they have not had an infection, then we vaccinate them, because rubella can be quite dangerous in pregnancy. It can cause congenital anomalies. Also, we rule out diabetes, hypertension, thyroid problems. So the first step that we do, that is the first test, is the test on the man. That is a semen analysis, wherein we see the total count. The reference ranges are there. The normal is more than 15 million. And we also see the motility, how active the sperms are, and we see the morphology. So these are three things we see on semen testing. All the three parameters are very important, as we will see later on. So what are the tests on the women? Tests for ovulation. We know that the egg has to get released, right? So we check the ovulation. And one simple way a woman can check at home is using a LH kit. But it is not 100% reliable. But if she just in the early part of her treatment, a woman may not visit the doctor again and again. Now, LH kit is like a pregnancy test. Just like that, the woman has to put some drops of urine late in the afternoon, like around 4 o'clock, and see if there are two lines or one line. If there are two lines, that means the hormone, that is a luteinizing hormone, that is the LH, has been released. And now we know that when the LH is released, 24 hours to 48 hours later, the egg is going to get released. So a woman can use this to understand whether the egg is getting released and when to have a relationship. So other way we see is, which is more definitive way, when the woman comes to the clinic, we check the ultrasound, whether the egg is, what we do is something called as follicular scan. We monitor the egg, the growth of the egg, and we see whether it has ruptured. So some tests that we do are thyroid and prolactin. If the woman is having irregular cycles, we may have to do this test. And of course, the rubella immunity. So how do we test the fallopian tube? There are two ways of testing it. One is in the outpatient department. We can just inject a dye through the mouth of the uterus and take an X-ray. This is called as a hysterosalpingography. And this is a simple, non-invasive, minimally invasive, you may say, test done between 7 to 10 days of the cycle. And it is about 80% sensitive. Here you can see the X-ray. The uterus is demarcated and the fallopian tubes are demarcated, and there is some spillage of the dye which comes out from the fallopian tube. So in this case, the fallopian tubes are patent. The other test that we do is a laparoscopy. A laparoscopy means we put a telescope through the umbilicus and we visualize it with the help of a camera, and we see whether the dye is coming. We inject the methylene blue dye and we see. This is done if the HSG, that is the hysterosalpingography, is abnormal, or we suspect problems. We do it straight away. That is, if the woman is having history of suggestive of pelvic inflammatory disease like pain, tenderness, then we may do laparoscopy directly. So this is what we see on laparoscopy.
Methylene blue dye there, and then
this
you
is the
can
uterus.
see this is just
This is the
supporting
fallopian
the
tube. And
grasper,
when we
and you can
inject the
see
dye,
it
we can
has
see the
become blue. The
dye
right side of the
spillage.
tube was open. Now this is left side.
This is the ovary.
This is
White
ovary
structure is the
fine.
ovary.
This left side of the tube is also completely patent. The blue dye is coming. That way, tubal patency test you can perform. It's a very simple.
So sometimes we may find a blocked tube. on HSC. This is a proximal block because the dye has not come out beyond the opening here. In these cases, we do something called as tubal cannulation. This is a video of that. This is the hysteroscopic view. We put a telescope through the cervix and look inside the uterus. And this is the opening of the tube, the ostia, which we call. This is the other opening. This is the cavity of the uterus. Now on laparoscopy, after injecting the dye, there is no spillage. Now the dye is actually being injected, but you can't see the blue dye coming out from the opening of from the fallopian tube. So there is no spillage here. This side also there is no spillage. So now we put in a catheter. This is a cannula that we put through the opening. The result here may be some mucus plug, or there might be some debris which are blocking both the sides of the fallopian tubes. So when this is put and then the dye is injected through the tube, and now there is a spillage. You can see the light blue color which is coming out. So this is called as a tubal cannulation. This is again repeated on the other side. So how do we treat infertility? What are the medical management? What are the medicines that we give? Now, when the egg is not forming, we do something called as ovulation induction, like in polycystic ovarian syndrome, where the egg is not forming. These are the drugs that we use: clomiphene citrate, letrozole, or we sometimes use injections like follicle stimulating hormones, or we may do myomectomy or fulguration of endometriotic deposits that we talked about. The third thing that we have is intrauterine insemination, and the fourth thing is the IVF. So we have a stepwise approach depending on the clinical profile and the investigations. The first test, of course, first step is basically naturally. And as we have discussed, there is a chance of success of 8% every month, and by 1 year, 80% will have a child. But if they don't conceive, then we do ovulation induction and tell them to have a natural intercourse. This we try for at least 6 months to 1 year, and the success is about again 10% per month. This is done especially if the woman is not ovulating. The third step is ovulation induction with intrauterine insemination that we will be talking about. Here, the success of conceiving each month is about 15 to 20%. So up to here, everything is happening naturally. The sperms are, even in intrauterine insemination, we just inject the sperms, but everything else is happening naturally. And the last step is IVF, wherein the success rate is much more because we are directly putting the baby inside, that is 40 to 50%. So IUI is done at least 4 to 5 times before we think about IVF. So what is intrauterine insemination? Intrauterine insemination is a process by which the semen is collected and it is washed so as to remove the immotile and dead sperms and all the contaminants like pus cells, and only the healthy sperms are injected directly with the help of a catheter in the uterus. This is in synchrony with the release of the egg. So how does it help? It helps because the concentration of motile sperms are increased. Now, normally, as I told you, even though there are millions of sperms in the semen, only few thousand reach the fallopian tube. Whereas in IUI, millions of sperms are good, healthy, motile sperms are deposited directly inside. So, and also, in some women, there might be a mucus plug in the cervix, which may be hampering the transport of the sperms upwards. So, when we put a catheter directly inside, it bypasses the mucus plug. So, somehow it helps in some women, this treatment. So, we will see how it is done once. So the semen is collected, and then it is first inspected under the microscope. These are the sperms. There are dead sperms, motile sperms, pus cells. Now they are added to a gradient solution and then centrifuge. This gradient solution acts like a filter, and only the healthy sperms form a pellet. And now this supernatant is discarded, and the pellet is again mixed with the sperm wash medium and then centrifuged again. And then the supernatant is discarded, and now the pellet which contains healthy sperms. These are the motile sperms. We have seen that all the unhealthy sperms have been. The healthy pellet is then loaded onto a packet, into a syringe. Attached to a catheter. And then injected into the uterus. This is the ultrasound picture. Semen going inside. So this is basically the intrauterine insemination. As I said, only the injection of the sperm is from our side, but fertilization and embryo development happens naturally. So this is one video which I took from the internet. So for whom is IUI done? Well, the IUI is done if there is a sufficient number of sperms. If the sperm count is less than 5 million in the unwashed sample, then we cannot do an IUI. We have to think about IVF. Also, it depends on the motility and the morphology. So if the morphology, that is more than 14%, is good, then there is a higher chance of conceiving with IUI. So these criteria have to be matched. Only then we can expect success. But if the count is less, the motility is less, the morphology is poor, then IVF is the only option. So what exactly is IVF? As we have seen, the majority part of baby formation, that is the cleavage division up to day 5, happens in the fallopian tube. IVF is just mimicking this in the external environment, that is in vitro fertilization. That means the fertilization, division and cleavage happens in the lab. So IVF was actually developed by these two scientists, Robert Edwards and Patrick Steptoe. Well, there is a very interesting story. If you want, you can read it on the internet. The Robert Edwards was a physiologist who was studying animal eggs, and then subsequently he moved on to human eggs and tried to fertilize them externally. And after a lot of research, he could fertilize a few eggs outside and grow them into embryos. Now, Patrick Steptoe was a gynecologist who was a pioneer in laparoscopy. So they had a chance meeting in one of the conferences, and Patrick Steptoe helped Robert to obtain eggs from infertile couples through a laparoscope. And there was a lot of hue and cry when they start doing this process, and they had a lot of criticism. But finally, on 25th July, that is today, 1978, this baby was born. That is, was named Louis Brown. And over a period of time, now IVF has gone through a lot of criticism and a lot of ethical considerations. The church was against it, but now this has become one important milestone in the treatment of infertility and has been widely accepted. About 8 million babies have been born so far through IVF. And finally, in 2010, Robert Edwards was given the Nobel Prize. Patrick Steptoe missed it because he passed away early. So Nobel Prize is given only to people who are alive. So Robert Edwards received the Nobel Prize for his work in this department. So what has changed since Louis Brown? Well, Louis Brown's mother had ectopic pregnancies on both the sides. So both her fallopian tubes were removed. So IVF was mainly used for the tubal factor. But now the indications for IVF have increased. As we can see, it is also used now in male factor, endometriosis, ovulation dysfunction. Now, this is the tube that I showed you, which is blocked distally. It's blocked somewhere at the end. The dye comes till the end but doesn't spill. This is called as a distal tubal obstruction. We cannot do anything surgically for these patients, and IVF is the only option for them. Or if the male count is less, IVF is the option. Or in cases of severe endometriosis, we consider IVF directly. Or if they in mild to moderate endometriosis, we do IUI at least 4 times, and if it fails, then we do IVF. Also, in women who have and men who have everything normal, which we call as unexplained, in those couples also we do IUI 4 times, and if it fails, then IVF is indicated. IVF can sometimes explain the cause of unexplained infertility. Some women may have fertilization failure, or there may be some sperm defects. So IVF can also become a diagnostic modality for these women. Also, women with anovulatory dysfunction, that is polycystic ovaries, if they don't conceive in 12 cycles, then we consider IVF. Now, women above 40 who have very remote chances of conception because of poor egg quality can conceive with the use of donor eggs, and they have the same chance as a young lady. If use of donor eggs has revolutionized the treatment for these people, and they have the same chance of having a baby as that of a young couple. Also, women who don't have any the uterus, or if they have a problem in the uterus like adhesions, or if they're having repeated miscarriages, then IVF may be considered. Or they have some medical conditions like a renal disease. IVF is done, and then the embryos are transferred into a healthy lady. This is called as a surrogacy. So we take the eggs and we fertilize them, and then the embryo is transferred into a surrogate. This is called as gestational surrogacy. So what is this IVF procedure? Here in IVF, what we do is we give them some injections so that multiple eggs form, and then with the help of a transvaginal ultrasound, we put a needle and aspirate the eggs. These eggs are then taken in a petri dish. They are separated. The mature eggs are separated and then mixed with the sperms. And then the result, then this is incubated in a carbon dioxide incubator. And the resultant embryo is then transferred into the uterus, either on day 3 or day 5. So this is one video. IVF involves
fertilization,
follicle aspiration, fertilization,
and
and
embryo
transfer.
transfer. During the first procedure, called follicle aspiration, eggs will be harvested from the ovaries.
So
At the beginning of this procedure, an ultrasound probe will
the
be
ultrasound
inserted
probe
into
is
the woman's
inserted.
vagina so that her doctor can view her ovaries.
The ovaries are visualized.
Inside the ovaries, the doctor will look for follicles. Each follicle is a fluid-filled
The
sac that
follicles
contains an
are
egg.
being inspected. A
Then
needle
the
is
doctor will
passed
insert a
through the
long, thin
vagina. This is
needle
under
into and
anesthesia.
through the wall of her vagina and guide it to the ovary.
And then
A
the
suction
follicles
device
are
connected to
aspirated.
the needle will collect several eggs from inside their follicles. During the second part of in vitro fertilization, called fertilization, the collected eggs will be taken immediately to a laboratory where they will be fertilized.
These are then mixed, the eggs are then mixed with the
Fertilization
sperms.
may be performed by insemination, where several sperm are mixed with the healthiest eggs. Or the eggs may be fertilized with sperm injected directly into them during a process called
We will talk
intracytoplasmic
about this
sperm
intracytoplasmic
injection.
sperm injection.
The fertilized eggs, also called embryos, will be monitored for 3 to 5
So these
days as they begin
embryos
to
are then
grow.
incubated in the incubator.
At this time, the lab may create a hole
Sometimes
in the
we
zona
do
pellucida
something
surrounding
called
some of
laser
the
assisted
embryos.
hatching.
This process,
If
called
the
assisted hatching,
covering of
will
the
help
egg is
these
very
embryos
thick,
implant in the uterus.
we create a small
Some of
opening.
the embryos will be used right away for embryo transfer,
These are then
and the rest will
transferred
be
into the
frozen and stored for
uterus,
future use if
and the extra
necessary.
embryos are sometimes frozen.
The third part of in vitro fertilization is called embryo transfer, which is done 3 to 5 days after fertilization. During embryo transfer, a tool called a speculum will be inserted into the woman's vagina so that the doctor can see her cervix. A syringe
So the
will be
embryos
loaded
are
with
loaded.
fluid containing one
On
or
the
more
third or
of
the
the
fifth
hatched
day, they are loaded
embryos.
into the
Then the
catheter.
syringe will be attached to a long, thin tube called a catheter. The doctor will insert the catheter into the vagina,
This is exactly like
through
an
the
IUI.
cervix, and into the uterus.
And then the embryos are released.
Once inside the uterus, the doctor will inject the embryos. Then the catheter and speculum will be removed.
And woman is
The
given
woman may
rest for
continue
about
to
15
lie
to
on her
20
back
minutes, and then she
for a
can go home. This is a very simple process, the embryo transfer. For egg pickup, anesthesia is required. So what are the problems that we face in IVF? One is important for problem that we face is fertilization. Now, if the count is low, then fertilization will not happen naturally. That means when the egg is mixed with the sperm and left like that, it doesn't fertilize. At least 1 lakh sperms are needed per oocyte for them to fertilize. So fertilization failure was one important problem that we earlier faced during the development of IVF. But since 1993, a technique was developed called as intracytoplasmic sperm injection, wherein the sperms are directly injected into the egg. This is one of the videos. So this is under this microscope. This is an inverted microscope. The sperms are picked up with the help of a injection needle. This is the egg how it looks under the microscope. So now, because of this process, even men with no sperms in the semen can conceive. We can obtain the sperms by inserting a needle. This man will have some sperms in the testes. So we obtain them from the testis itself and then use this process of intracytoplasmic sperm injection to achieve fertilization. The other hurdle that is there in IVF is the cleavage and the growth. Now, the growing the embryos externally is like one of the most difficult process, and a lot of research has gone through it. The embryos are very sensitive to temperature, humidity, pH fluctuations. So this was the lab in which the first IVF was done, and over the years, this is our modern lab. This lab is basically has a concept of clean room technology, wherein the air which comes is filtered with HEPA filters and VOC. The embryos don't like even a slightest smell. So that is very important to achieve a better success. So this is Louis Brown, and she is holding the bell jar that in which her embryos, in which she was grown. And this is the benchtop incubator that we are using now. So we have come a long way from bell jars to benchtop incubators. Also, the media that was used was simple media, whereas now we use quite advanced media wherein the success has improved. So Patrick Steptoe and Robert Edwards had to do at least about 110 trials before they achieved one pregnancy. But now we get a success about 40 to 50% in one cycle. So it is because of these advancements that the success has improved. This is another important milestone, that is cryopreservation. This is a wood frog, and in nature, this wood frog freezes itself in winter. So man has been trying to freeze his own cells since many years, and now it is possible to freeze a human embryo or a sperm or a egg with the help of this technology, that is vitrification, wherein the gametes are treated with a special medium and then frozen rapidly at minus 120 degrees Celsius per minute, and then frozen in liquid nitrogen up to temperatures of minus 196, and the cells remain in suspended animation, and they can be thawed after any number of years, and we obtain a good chance of survival of about 80 to 90%, and pregnancies of ranging from 45 to 50%. So this is the chamber in which we freeze, and these are the straws in which they are frozen. What are the advantages of this embryo cryopreservation? Now, if there are extra embryos, we don't have to throw them out. We can freeze them, and the woman need not undergo all the process of IVF again. Only the embryos are stored. The stored embryos are taken out and then transferred. So if one IVF fails, there are extra embryos, we freeze them, and then we can use them. Also, something called as social freezing. You must be knowing about Diana Hayden, who froze her eggs in her mid-30s to delay her childbearing. So the eggs can also be frozen, and this remain frozen in time. So this is one important development that has happened. Also, in cancer patients, the eggs and the sperms can be frozen before using chemotherapy or radiotherapy, which may be detrimental to the gametes. The success of IVF depends on the age. When Louis Brown was born, in that era, the success was about 10% or 5 to 10%. But now the success is about 43 to 50%. But it depends on the age. And as age advances, the success in IVF also goes down. So what are the risks of IVF? Many people know that IVF can lead to twins. But now, because of better culture conditions, we can grow the embryos to day 5, and we can transfer only one embryo, which gives a equal success as compared to transferring 2 or 3 embryos. So now the chances of twins are definitely less in centers where we transfer single embryo. in our practice, we transfer 1 or 2 embryos. So whether there are any abnormalities in the baby, there is one important question that is asked. Well, we should remember that in a general population, the baseline risk of congenital anomalies is about 3 to 5%. That means, suppose there is a population of 100 pregnant women, then there will be a 3.3 to 5% risk of having an abnormal child. In IVF, the risk is about 4 to 5.5%. But this is not mainly because of IVF, because in one study, they found that even in women who have a problem in conceiving, and those women which conceived after many years, they also had the same risk as IVF, that is about 3.5 to 6%. So it is not the problem with the IVF, but it is the problem with the clinical profile of the couple. Because they have a chance, they have a infertility, there might be something that may be causing the problem, the congenital anomalies. So as a whole, IVF is safe, and there is not much increase over the baseline. So to summarize, preconceptional health of the couple is very important before they try for pregnancy. Lifestyle changes, stress, environmental toxins, delay in childbearing have led to increase in infertility. Advances in reproductive medicine, especially IVF technology, have improved the chances of conception in couples who otherwise had no hope of conceiving. And IVF has become patient friendly. There have been very less complications, and the long-term follow-up of this IVF is reassuring. So this is Robert Edwards. This is Louis Brown. This is now her baby, and this is her mother. And today is Louis Brown's 43rd birthday. This is a coincidence that 25th July. Today is 25th July, and this is a 43rd birthday. And this is Subhash Mukhopadhyay, who was a pioneer in India, and he is largely unknown because Durga was born 3 months after Louis Brown. But he has many firsts to his credit. He was the first to use gonadotropins to stimulate the ovaries. He retrieved the eggs vaginally, as against the European team, which used a laparoscope, which is more invasive. And he was the first to freeze the embryos. But he has not received much credit, thanks to his peers, who thought that he was faking it all. And ultimately, this man had a very unfortunate ending. He committed suicide because he was harassed. But now lately, in few years back, people have gone through his papers and articles, and then we have found that Durga was actually an IVF baby, was born 3 months after Louis Brown. So now this man actually has not received much credit, but we know that his contribution is important in IVF. This is our lab in Vision Hospital, and this is our team. Thank you.
Thank you, doctor.
Dr. Melissa, please take over.
Doctor, you were quite informative, and we already got a lot of information from your webinar. But we have two queries our participants have asked us. The first one is, does high prolactin levels cause infertility, and how it can be treated?
Yes. So prolactin levels can cause infertility, because as prolactin levels goes on increasing, the process of folliculogenesis, that is the egg formation, is hampered, and women may have symptoms like oligomenorrhea, that is delayed cycles, or they may have amenorrhea. So as the prolactin keeps on increasing, the women has a spectrum of problems, and that can lead to infertility. So it can be treated with something called as a dopamine agonist, that is bromocriptine and cabergoline. It is one of the easiest way to treat. But before we treat, if the prolactin is high, we need to investigate whether what is the reason for the increase in prolactin. It can be increased because of medicines, that is people who are taking psychiatric medicines, or even nipple stimulation. So prolactin is very sensitive that way. Then some women may have some CNS lesions like craniopharyngioma. So we have to do a MRI of the brain. If prolactin is more than 50, then we need to investigate why the prolactin is high. And treatment mainly, even in cases where there is a microadenoma or macroadenoma in the brain, treatment is mainly medical, that is cabergoline or bromocriptine. And if there is any resistant cases, we may have to resort to surgery in cases of CN adenomas in the brain. But prolactin is very easily treated, and people achieve fertility as soon as prolactin comes to normal.
Okay. Thank you, doctor. Going to the next question. How is infection in fallopian tubes diagnosed and treated?
Yeah, the infection in fallopian tube may remain undiagnosed, meaning, as I said, chlamydia is one of the most common organisms, and it may not cause any symptoms at all, but it destroys the hairs like cilia lining, which is the conveyor belt for the egg. It can easily destroy it, and that is very difficult to see on a hysterosalpingography or laparoscopy. In HSG, we just see whether the tubes are open or they are closed, but we cannot see the microscopic hair lining. So if there is a gross damage, yes, we can easily find it out on a HSG or a laparoscopy. But the damage which happens, which is microscopic, may never be able to diagnose. So unexplained infertility, in these cases, there might be a this factor which remains in them. The fallopian tubes may be normal, but the microscopic cilia may be damaged because of chlamydia. So it is not very easy to diagnose unless we take a biopsy and see it. So yes, HSG and laparoscopy can detect gross blockages of the fallopian tube. Also, we can suspect pelvic inflammatory disease in women who have vaginal discharge or pain. In that, if it is diagnosed early, in them we can treat it with antibiotics, and it is 100% cured. But if it is diagnosed late, then the damage is irreversible.
All right. Thank you, doctor. With that, we come to an end of the question and answer because the rest of the matter was quite simplified. Thank you once again.
Hello.
Yes, Lavi, you're audible. Dr. Lavi, you're audible.
Good afternoon, one and all. I, Dr. Lavi Jain from IAP Women's Cell Goa State Team, would like to take this opportunity to present the vote of thanks for today's webinar. On the behalf of IAP Women's Cell Goa India team, extend a very heartily vote of thanks to Dr. Sachin Narvekar sir for giving valuable talks to our IAPWC Goa branch on infertility, what, when, and how we treat it, for gracing the webinar with your important work and sharing with us your findings and opinion today. Would like to thank all the delegates for making this webinar a successful event. I would like to thank the whole team of IAPWC Goa for organizing this. Last but not least, I thank the IAP technical team for the support and providing us with this virtual platform to reach out to the entire physiotherapy community. Once again, a big thank you to Dr. Sachin sir for coming to this webinar. Thank you.